Hello, and welcome to today's Facebook Live hosted by the Global Heart Hub. My name is Celina Gorre, and I am the CEO of WomenHeart. Our mission is to improve the lives of women with or at risk of heart disease while fighting for equity in heart health. Today, I've been asked by the Global Heart Hub to moderate this event, and I'm thrilled to be joined by a panel of experts who are just as passionate about the topic of atherosclerotic cardiovascular disease, or ASCVD, the umbrella term which includes heart disease and strokes. We'll invite our panel to introduce themselves briefly, and then we'll get right into it. So first up is Dr. Shaun Goodman.
Thank you, Celina. Thank you for the opportunity. Hello, everyone. My name is Shaun Goodman. I'm a cardiologist. I work at St. Michael's Hospital, and this is in Toronto, Canada. I'm also a professor of medicine in the departments of medicine at both the University of Toronto and the University of Alberta in Edmonton.
Great. Thanks, Shaun. Next up is Magdalena Daccord.
Hello, everyone. My name is Magdalena Daccord, and I'm Chief Executive of FH Europe, the pan-European network of patient organizations advocating for patients and citizens affected with inherited lipid conditions, which very often, undetected, lead to premature atherosclerotic cardiovascular disease. Thank you for having me today.
Thank you, Magdalena. And Neil Johnson.
Hi, everybody. My name is Neil Johnson, and I'm coming to you from the west of Ireland, Galway City. And I'm the Executive Director of the Global Heart Hub, which is a relatively new organization, being an umbrella organization of international heart patient organizations. I'm delighted that we are hosting today's event, and thank you, Celina, and welcome, Shaun and Magdalena. Thank you so much for being part of this discussion.
Great. Thanks, Neil. So before we start the event, I'd like to remind the audience that we want to hear from you as well if you are part of this conversation. So please share questions and comments in the chat, and hopefully we have time at the end so that our experts can answer some of your questions during the Q&A session. And so during this event, we will discuss ASCVD, what it is, who's at risk, and what we're doing together to expose the realities of ASCVD, so that we can tackle the challenge that the status quo is serving up. And it's a global health issue. So listen up, and hopefully we'll provide some information that's really useful for you today. So with that in mind, I'd like to invite Shaun, if we can start with you. The first question goes to you. Our audience is here because we have an interest or curiosity about ASCVD, or atherosclerotic cardiovascular disease. So we'd love for you to give us an overview of what ASCVD is and what the consequences are.
Great. Thank you, Celina. So atherosclerotic cardiovascular disease, or ASCVD, is an important disease that pretty much affects or will affect each and every one of us over the courses of our lifetime. Within the broad collection of diseases of the heart and the blood vessel, and hence the term cardiovascular, many people, if they live long enough, will ultimately develop atherosclerosis. So in the early 1900s, a German pathologist coined the term atherosclerosis from the Greek athero, meaning pasta or gruel, and sclerosis, meaning hardening, to describe the fatty substance, cholesterol, that formed a plaque inside of a hardened artery. We now know that the main initiator of atherosclerosis is inflammation. And inflammation can affect the cells that line the blood vessels. When these cells aren't working properly, that allows cholesterol to enter into the walls of the blood vessels. Now, we all know that cholesterol comes from what we eat, but we also make, in fact, most of the cholesterol that ends up in our bloodstream in our livers. And I know that we'll hear more about this shortly from Magda, but I wanted to point out that there are some people that are born with a family tendency to have a very high level of cholesterol circulating in the bloodstream. For example, approximately 1 in 250 to around 1 in 300 people worldwide can inherit this genetic condition called familial hypercholesterolemia, or FH. Now, once the cholesterol gets into the walls of the arteries and starts to accumulate, it can form these plaques. And the plaques can cause narrowings that then restrict blood flow. So that limits or prevents the red blood cells that are floating around in our bloodstream that carry oxygen and the nutrients from reaching the vital organs like the heart muscle and the brain. So the clinical manifestations or the way that we're aware of ASCVD often is when people have conditions that relate to cerebrovascular disease related to the brain. And people are probably familiar with the terms stroke or transient ischemic attack, a TIA, which is a sort of a threatened stroke, or coronary artery disease in the arteries that supply the heart muscle. People can get chest discomfort or shortness of breath, difficulty in breathing. And if there's a prolonged blood flow blockage from one of those narrowings, one can ultimately have permanent damage, for example, to the heart muscle. We call that a heart attack. One of the biggest challenges is that many people really don't experience these symptoms or any symptoms beforehand, because with ASCVD, the plaques might not cause any particular problems until all of a sudden they rupture, they ulcerate, they erode. And this can lead to thrombosis or clot formation in the arteries, which blocks off all of the blood flow, and then again can cause a heart attack, or leading up to the brain can cause a stroke. So all of these types of ASCVD can lead to permanent disability and unfortunately sometimes death.
Thanks, Shaun. And I understand that there's a growth in the burden of ASCVD worldwide. Can you explain why that is?
Yes. I mean, first of all, it's incredibly common. It's estimated that about 2 billion people are at risk for developing ASCVD, and 300 million people are currently living with ASCVD. Now, cardiovascular disease is the leading cause of death and disability around the world, and it accounts for about 1 in 3 of all deaths that occur. 85% of all cardiovascular deaths are related to specifically ASCVD. Let me put this in absolute terms. There are approximately 15 million deaths per year caused by ASCVD. And even over the past year, during this terrible pandemic, cardiovascular disease still accounted for 2 times as many deaths than those from COVID-19. And deaths from cardiovascular disease, as you note, Celina, are increasing over the past 15 years and are expected to rise even further. The cardiovascular death rate has increased by approximately 15% over the past decade. And we expect by, for example, 2030, less than 10 years from now, that number of 15 million deaths a year may rise to as many as 24 million deaths. So, and, in the past minute that I've been describing all of those things, approximately 34 people with atherosclerosis have died from a heart attack or a stroke. That's unfortunately how common this condition is and how devastating it can be. Now, there are multiple reasons why approximately 1 in 4 of us have this plaque buildup from atherosclerosis in our arteries, and the burden continues to grow. And even though we're making some progress in identifying and treating patients with risk factors for ASCVD, for example, by lowering blood cholesterol and treating patients who have high blood pressure, we're also seeing an increase in the number of individuals who are overweight, who have diabetes. We're seeing the largest growing segment of people who are taking up smoking, unfortunately, are young women. So we have, of course, finally, a growing population of older individuals. So in this case, ASCVD is a growing global problem that needs to be better addressed. And I think that starts with increasing awareness, hopefully like what we're doing today.
Thanks, Shaun. Now, you've already gone into a little bit about, who is at risk and what types of behaviors perhaps might make somebody, put somebody at higher risk. But can you talk a little bit about why that is, and also talk about maybe sort of the the asymptomatic notion that, so ASCVD, you can have it without knowing it. Can you talk a little bit about that?
Sure. All of us are at risk to develop ASCVD. As I mentioned earlier about atherosclerosis, hardening of the arteries, but it appears that this has been around pretty much forever. For example, recently some investigators using a computed tomographic assessment, people know that term by a CT or a CAT scan, a special way of imaging the arteries. When these researchers did CAT scans on Egyptian mummies, they discovered that these humans had developed hardening of the arteries, atherosclerosis, including of the coronary arteries that supply blood to the heart muscle, even in individuals at that time that died at relatively young ages. So those who are at higher risk include those who have elevated levels of cholesterol. And cholesterol is this sort of soft, waxy substance that's made by our bodies. I mentioned, I think earlier, that about 20% of it comes from what we eat, mainly from saturated fats and trans fats and foods. But the majority of the cholesterol that's circulating in the bloodstream is made by our livers. So it's important to recognize that even if we eat properly, our livers may still make more cholesterol that circulates in the bloodstream, at least more than our arteries would like. And dietary cholesterol doesn't affect blood cholesterol levels to the same extent in every person. It varies from individual to individual. So other risk factors for ASCVD beyond cholesterol include smoking or even exposure to secondhand smoke, high blood pressure, also known as hypertension, diabetes, diets high in saturated fat, cholesterol, and calories, but unfortunately low in fruits and vegetables. We know that excess alcohol consumption, physical inactivity, being overweight, and importantly, psychosocial factors, stress, can be a great contributor, unfortunately, to inflammation and atherosclerosis. So collectively, these factors account for probably more than 90% of the risk that people ultimately have for developing ASCVD. And to your important question, unfortunately, ASCVD can be a silent killer because most people don't develop symptoms until the narrowings and blockages from atherosclerosis have reached a critical stage. And so that's important. For example, in FH, familial hypercholesterolemia, people who are born with high levels of the bad cholesterol, in particular, what we call low density lipoprotein, LDL cholesterol. If this is not recognized and not treated, this can lead to premature atherosclerotic cardiovascular disease development and events. So this, again, can be something that people are not aware of until they have a catastrophic event.
So, Shaun, let's put another lens on the discussion about risk. Talk about modifiable versus non-modifiable risk factors, and what does that mean in the context of ASCVD?
Right. And this is important because we want to know what we can and what we can't control and need to be aware of both, of course. So some risk factors for ASCVD are not modifiable. In other words, we can't change those things. For example, a premature family history, an older age, and sex. Women are apparently, in some cases, protected by hormones prior to menopause, but unfortunately, they do catch up to men with respect to developing symptoms and ASCVD, on average, maybe 8 to 10 years later than men, but they do catch up. And so that ultimately there's about a 50-50 split with respect to the sexes for the development of ASCVD. And I also want to point out, while I'm on the topic of women, women and their healthcare providers tend to underestimate their risk of ASCVD. For example, about 1 in 3 women perceive breast cancer as the major health threat to them, understandably. But in reality, cardiovascular disease is actually responsible for twice as many annual deaths as all cancers, including breast cancer, combined. And then back to FH, of course, we can't change this. It's genetic. It's an inherited high cholesterol condition. but we can easily identify FH patients starting with a simple cholesterol blood test. We can dramatically change the course of FH if it's recognized and treated early enough. Now, if we turn to the factors, the risk factors for ASCVD that are modifiable, that are somewhat within our control, those relate to high cholesterol, high blood pressure, smoking, diabetes, being overweight, the things that I mentioned before. And these can be modified or changed to some extent, and we can lower our risk of developing ASCVD and maybe preventing about 80% of premature atherosclerotic cardiovascular disease events if we can get our cholesterol treated, if we can adopt a heart healthy lifestyle, we can increase our physical activity, quit smoking, easier said than done, of course. And similarly, managing stress, not an easy thing to do, but these are things that at least partially are within our control to be able to modify to the best of our ability. But of course, if people aren't aware of having ASCVD, it's not clearly within their control to modify even these risk factors. And I just want to finish up by saying that, I've been in this space for about 30 years, looking after people with at risk for or with ASCVD, including doing some clinical research. And I think that the best way forward is to engage the person and their family. We need to move away from the sort of paternalistic physician-only approach in all of this. We need to engage all of the healthcare providers, not just the cardiovascular specialist like me, who happens to see a patient with ASCVD in the hospital after they've had their heart attack. But we need to better engage pharmacists, nurse practitioners, dietitians, nutritionists, and the primary care physician who's at the front with these individuals. And we need to empower the patients so that they can be their own best advocate. We have tools, I think. We just need to sort of coordinate better and enhance awareness to individuals. And I think that this is a potential winnable battle against ASCVD.
Thanks, Shaun. And I just want to underscore as the CEO of WomenHeart, I just want to underscore the point that you made about women and the often missed or underdiagnosed or delayed diagnosis of heart disease in women, because it's just not on top of mind for women themselves, but also for healthcare providers. So thank you for bringing that point. And on that point, I want to turn to Neil, because we're talking about awareness. And so, Neil, over to you. Do people living with ASCVD, do you think they truly understand the risks involved?
Yeah, at the risk of repeating pretty much what Shaun has said, I think I would say that it's really difficult to understand risk if you're not aware that you're at risk. So, and we do know, as Dr. Shaun has just mentioned there, that some people are at greater risk than others. FH being a very clear example, 1 in 250 to 300 people born with this genetic predisposition to a high level of cholesterol, which creates really what could be described as a lethal condition. We know that undiagnosed FH will result in a cardiac event or even death before age 40. So if we can find that index case, we're saving a life, but not only one life, but we potentially are saved many as well. We know, as already been mentioned, that women, for example, post-menopausal women are actually at greater risk than men at the same age. And we know that this is due to hormonal changes. We know that certain risk factors are measurable. So you can measure a level of cholesterol, you can measure a level of blood pressure, and there's an importance in knowing those numbers, because there is something of a predictive value to those scores in terms of how it can impact in terms of the damage they can do. But conveying the concept of risk to an individual is actually very difficult. It's even more difficult when the condition you're talking about is asymptomatic. So you feel okay, and you're told, well, your cholesterol is very high and your blood pressure is very high, and so it's very hard then to convince somebody that actually there is something happening within their system that if this continues can be catastrophic. So there's a huge need for greater awareness. There's need for greater education, And there's a need to somehow figure out what is the best way to convey that risk. You know, we use things like the heart age and various score charts and so forth, but I think we still are lacking some mechanism of conveying to people that people, particularly with ASCVD, that they're living with a long-term condition that needs to be addressed. So in terms of awareness, of course, there's huge imperative here and there's huge urgency. And again, at the risk of repeating the numbers, but it's important to repeat them. 85%, think about it, 85% of all heart attacks and stroke deaths are attributable to ASCVD. I mean, this is an enormous figure. 15 million deaths globally a year, 2 billion people considered to be at risk, and 27% or over a quarter of the world's population are living with this buildup of plaque in their arteries, which is a very dangerous situation. But it's not all bad news though, right? The good news is that 75 to 80% of ASCVD is actually preventable. And the key thing is to recognize the risk, and many of these risks are treatable. So while it's a very serious situation and a very scary situation in some respects, the good news is that there's a lot we can do, even for those people that we know have that lethal condition of FH. If we can, first of all, find them, we can treat them.
Thanks, Neil. I mean, these numbers are staggering, and I think, you know, all of us are kind of compelled to think about how we can work together to address it. So I want to bring Magda into the conversation and put a question to both Magda and Neil. I'd love to hear what you both think are the main challenges. Why are we not currently winning the fight against ASCVD? What are the challenges in terms of managing ASCVD? And let's start with you, Magda.
Thank you, Celina. The short answer is it's multifactorial. Before we even get into the challenges in ASCVD management, we need to address the challenges of low awareness, followed by low detection and diagnosis rate. And I would like to start with that. So perception, or better said, misperception. So let's imagine we hear someone around us suffers from CVD, cardiovascular disease. And now, after a clear presentation by Dr. Goodman, it is highly possible it is ASCVD we're talking, so atherosclerotic cardiovascular disease, which we know is due to high cholesterol. Suddenly, a classic picture pops up in our head, a typical patient profile, an unhealthy individual having a high-fat, high-cholesterol diet, sedentary lifestyle, lacking any physical activity, possibly even someone smoking. Everything we've heard so far. But that's not necessarily true, and surely not for the community I represent here today. I represent the community of patients and their families, specifically bloodline relatives, as well as citizens, and I will explain in a second why I refer to citizens here, affected by what we heard earlier, genetic inherited risk factor, which is non-modifiable. So low awareness among public and doctors. FH specifically, familial hypercholesterolemia, is the most common genetic condition in the world, which affects over 30 million people around the globe. As Dr. Goodman said, we have 1 in about 300 persons born with it. It might differ depending on the geography, but it's roughly 250, 300. And let me add, to be a little bit more realistic, but at the same time dramatic here, a child with FH is born every minute. However, there's an issue with detection. Only 1 person in 9 are diagnosed correctly. That means that 90% of people globally born with FH are absolutely unaware, and they probably never heard of FH. I would even dare asking, if I could, how many of you joining us today have heard of FH before? And so they're not patients as such, as by the definition. They are citizens because they are not aware. They haven't been detected. They have not been diagnosed. The low awareness is as well noticed, observed among doctors. And that very often leads to undertreatment or inappropriate treatment. Despite available guidelines, most of the patients with FH do not meet their recommended targets. And in FH specifically, we need to understand we're talking about combination treatment. We need to sometimes, well, very often, take several pills, medications to reach those targets. But as everyone said before me, and I'm going to repeat it a little bit, ASCVD is invisible. So it is difficult to adhere to treatment on a daily basis throughout your life for something that you do not feel and do not see, asymptomatic. There's one other thing. We're talking about prevention. It's so difficult to take medication, not even knowing that something bad might be just around the corner, hoping that we will do the right thing and prevent it. So maybe shortly, what does it mean for the families affected by FH? The ones that have not been detected suffer unnecessary and preventable heart attacks, strokes, and unfortunately, we need to say it out loud, even death. Most time, FH patients are diagnosed by a cardiologist at the time of their first event, which is a heart attack, which occurs prematurely at the age of 40. And ladies and gentlemen, this is way too late. We know from the global registry that adults are identified at the age of 40. Children are identified as a result of a tragic event because of their parents being identified. This is unacceptable, and it shouldn't be happening, especially in the era where we have available knowledge and tools and screening techniques as well as medication available. Last sentence, FH is often called a disease, but if detected timely, becomes a CVD risk factor, which treated, we can effectively keep under control. So let's detect the detectable and prevent the preventable.
That's great. Thank you very much, Magda. Neil, what are your thoughts in terms of the main challenges in global ASCVD management?
Well, to add to what Magda's just said, I think the biggest challenge is the issue of priority, and to what extent this issue is a priority for our governments and our leaders. Because the reality is that this is a global health issue. If you look at in just in pure sheer terms of impact and scale, this is so huge. The only way it can be addressed is at the level of international governments with collective action. Health systems across every country in the world are crumbling under the burden of ASCVD, because it leads to long-term chronic conditions, which are recurring revolving door expenditures in our hospitals and in our primary care centres. The financial costs, we could stay here for the day discussing the figures. They are shocking, they are frightening, but for some reason, we're not really doing anything about it. At the level of the human cost, we've heard already, a third, think about it, a third of all deaths directly attributable to ASCVD. The burden of heart attack and stroke, disability, ill health, death, all attributable to something that we can, that we know is largely preventable. So how do we get attention to this? How do we address this complacency? At the level of the individual, I think, it's almost to the point where people think, they look at heart disease and they think, yeah, you might die or you recover. You fall into one of those two groups. And if you die, invariably it's sudden and the story is over. And if you recover, it's a case, I want to forget about that, and life goes on. But the reality is we need to understand why those people died, and we can explain it as ASCVD. And then we also need to look at those who recovered and understand that you actually haven't recovered. If you draw the analogy to cancer, for example, you're almost, I won't say in remission, but you've got a lucky break, because ASCVD is an insidious, slow burning condition. And if you've had an event, you are at greater likelihood of a further event. But the good news, as I said, is you can intervene. There are treatments available, and there are methods of bringing about the change that's necessary to have a prolonged and good quality of life. I'm almost struck by always struck by the individual I met some years ago as I was walking through the local coronary care unit in the hospital, and I saw this young man around the same age as myself at the time, and he was carrying his duffel bag and passed me on the corridor, and I looked at him and said, "Oh, I didn't realize you were in hospital." And he said, "Yes, I had a heart attack out walking 2 days ago. But the ambulance had me in here in 45 minutes. I've had 3 stents, and I'm out the door now." And that was a great success story. But it was very clear to me that individual did not realize that his journey is only beginning. For him, it was, "I've been saved." The reality is that's a warning sign. You need to address the circumstances you now find yourself in. Mm-hmm. And so there are so many disadvantages of the advances, if you like, that we have made, that we need to reframe how we're looking at the cardiovascular disease discussion. Again, another example would be, how often do we hear somebody say, "I have a touch of angina." Like, a touch of angina is like saying, "I have a touch of pregnancy." Angina is a symptom of ASCVD. But why do we accept that sort of language? The reality is, if you have angina, you need to be proactively addressing what is clearly a health concern.
Yeah. Thanks, Neil. And so I know that you and your Global Heart Hub team have been working on Invisible Nation. And so what I'd love to do is share a teaser video now, and then we'll come back to you to explain what exactly Invisible Nation is.
Can you see us?
We are your family, friends, and neighbors.
Living with ASCVD, atherosclerotic cardiovascular disease.
ASCVD is the underlying cause of 85% of heart attack and stroke-related deaths.
This is a disease that threatens all nations and races.
It's real, it's widespread, and despite the alarming numbers, ASCVD isn't widely known.
And too often, it's overlooked.
Every one of us is a statistic, accounted for, but largely unseen.
Most of us are unaware of our risk, or indeed the consequences of ASCVD.
We are
an invisible nation.
It's time to change the course of ASCVD.
To make the unseen seen.
To work together to reduce heart attack, strokes,
and lives lost.
To help the world see that reducing the impact of ASCVD
lifts every nation. Help us to be seen. Share this video and visit invisiblenation.com.
Great. Over to you, Neil, on exactly what Invisible Nation is.
Well, I think to explain the word itself, the clue is in the name, Invisible Nation, and perhaps it should be best described Invisible World. And as we've described and discussed just now, we're talking about something that's affecting 300 million people living with ASCVD, the majority of whom are undiagnosed. And in the case of those that we spoke about with FH, for example, we've just learned that only about 10% of those with that lethal condition are diagnosed. So there is this invisibility, if you like, about this huge number of people. And we really have to do something about this. We really have to highlight that it's time for change. It's time to change the status quo on this. And it's a disease of all nations. It's a disease of all races. It's a disease of gender, of all gender and all backgrounds. And while lifestyle, as has been discussed, is critically important, it's not just a lifestyle issue. We've heard about genetics, about family history, about gender, about aging. So factors that are outside of our control. So you just can't blame people and assume this is as a result of the way you've lived your life. And for that reason, we need more than just medical help. We need intervention and leadership at government level, at the level of policy. We need national and international prevention and early intervention strategies. But I ask you, how many countries in the world have such plans? I know that in Ireland, for example, right now, we actually don't even have a national cardiovascular health strategy, let alone a prevention strategy. And this is something that we as a patient organization in our country are pushing for. So Invisible Nation it actually is a collaboration, it's a co-creation between the Global Heart Hub and Novartis. And we launched this with Novartis as a multi-year initiative. And we're looking at to others to come on board, because this is a ground up initiative. It's the patients and the patient community hopefully leading the way. And we need to rally the global patient community, the general public and the clinical community to expose the realities of ASCVD, which, as we've just heard, is the world's biggest killer, bigger than COVID-19. And this is a very important point, and not to diminish COVID-19. But we need to capture the attention of our decision makers to address this pandemic in the same way as they addressed the pandemic of COVID-19. So we need to ignite conversation. We need to inspire action. We need to activate systemic change. It's not acceptable, I think, that we can continue to ignore this. ASCVD is the primary driver of all heart attacks and strokes, and indeed many other diseases. And the global mortality rate of 30% of all deaths being related to this, it's time to cry halt and say, look, we need to come together as a community from the bottom up and implore our decision makers at government level to bring about change.
And Neil, who can get involved? Can anybody get involved? Are we talking about individuals? Are we talking about patient groups, other organizations? Who exactly is sort of the target audience for Invisible Nation?
Well, right now, the target audience is everyone. This is an initiative that's being led by the heart patient community. And so we're initially trying to reach out to our own community and to get the conversation going. But ultimately, what we're trying to do here is to start a conversation. We need a collective voice. We need to have those conversations with family, with friends, with community leaders. Eventually, we want to get the conversation to the level where we're talking to policymakers and decision makers. But we won't get there until we get the grassroots level talking and realizing just how significant an issue is. And so we need that collective action. And I invite people today to join this conversation. And they can do so by visiting the Global Heart Hub website, invisiblenation.com. And I'd encourage you to share the content that's there, and we'll be updating that and adding more. And this content will be made available in a format that is shareable. And we're all used to sharing information now on digital and social channels. Let's do it. Let's push this conversation out far so that we create a fire and a momentum around this issue.
Shaun, Neil brought up the topic of COVID-19. So I'd love to get your thoughts on what lessons we might be able to learn from the collective response to COVID-19 around the world.
Yeah, I think Neil said it brilliantly. I think just like the response to COVID-19, we need to deal with this particular pandemic, that of atherosclerotic cardiovascular disease. We need to come together to make ASCVD visible. And that involves a team approach, including clinical research, and in the case of ASCVD, making an optimal diagnosis and initiating whatever treatment or modifying risk factors as we best can. And of course, one of the things that I take away from the pandemic, the COVID-19 pandemic, is that science, while it doesn't always have all of the answers, or at least not as quickly as we might ask for them, is the best way forward. And of course, it's been mentioned that the pandemic has placed this enormous weight on our healthcare systems, which are already overburdened. We've seen, for example, during the first wave, that patients with heart attacks and strokes often didn't come to hospital, or if they did, they came in a delayed fashion. understandably worried about getting infection. But these are safe places. And approaching your primary care physician, folks in your circle of care, safety measures are in place so that one won't get infected from COVID-19, and one shouldn't delay seeking treatment or attention. And I think the focus on the inpatient care has led to delays in diagnosing and treating ASCVD, and we're pretty worried in the cardiovascular community that there's going to be this sort of tsunami related to ASCVD that's going to follow as hopefully the COVID-19 pandemic settles a little bit, because people aren't getting their cholesterol checked, they aren't getting their blood pressure checked, they aren't on optimal treatment. In contrast, one could argue that the move to virtual care, maybe there's some advantages indeed to this, opportunities for individuals and their families to maybe even better connect in a more timely fashion with healthcare providers, so that we can hopefully address in the future ASCVD earlier, not later in its course. And I think anything we can do to prevent the development and progression is clearly a value to individuals, and engaging people at risk for or with established ASCVD at an earlier stage has the potential to provide some breathing room, I would say, to Neil's earlier point, in an already overtaxed healthcare system.
Magda, I want to bring you in and ask you about any real world examples that you can think of where there's been some successes in implementing programs at scale to actually change the trajectory of ASCVD.
As mentioned previously by both Dr. Goodman and Neil, it's a huge global problem, and it needs strategic, proper solutions. From a European perspective, I am delighted to share an initiative that we are currently in the phase of implementing, working, and just like previously said, tackling it from a multi-stakeholder perspective, bottom up, driven by patients, in collaboration, very close collaboration with scientists, with the medical community, as well as industry, and very important stakeholder policymakers. FH Europe, with partners like Global Heart Hub, as well as other representative organizations, is working on an implementation of universal early screening for FH, so that pediatric FH detection is reality across Europe. And hopefully, I truly believe, hopefully with the efforts of everyone involved, we will be able to make a big difference and detect those people, prevent the preventable, and create a best practice beyond Europe, so that prevention and detection happens in other areas of the world.
Great, Magda, thanks. And Neil, maybe same question to you. Given your role in the Global Heart Hub, any examples that you can think of successes of change at scale?
Well, when you talk about change at scale, probably COVID is the best example that we could give right now. And you stand back and say, what was it about, or what is it about the COVID pandemic that brought about such united international alignment on what the best course of action was? So if you were cynical, as I might be now, and say, was it the risk of death? Was that what was the driver about this? Because the reality is that the numbers, as Dr. Shaun has just said, is that the numbers for cardiovascular disease are actually twice as high as COVID. Or was it that COVID presented a burden that was going to crumble the hospital systems and the health systems around the world? Was that the real driver? I don't know. That's a debate for another day. But we, as a model, I would say that if an alien were to visit our planet today, and if we were to introduce them to ASCVD and say, look what happens in 1 year across the world with ASCVD, and you look at the numbers that we've just discussed, how could they not be forgiven for thinking that we are bonkers for not addressing this when it's largely preventable. And we have an example of COVID, where we were faced with this, again, enormous burden internationally, and governments came together, and we largely got our act together. So it is possible to do this, but it's going to require huge energy and drive. And I hope that what we're doing through Invisible Nation and through starting at, as I said, at grassroots level with the patient community, people who are living with this, that we can build momentum. We can bring the clinical community with us. We can bring the scientific community with us. We can bring the public with us, and we can eventually convince our leaders that we need a new strategy and a new approach to ASCVD.
Thanks, Neil, and thanks to the panelists. I want to bring our audience in, and we've got a question here around the differences in diagnosis from country to country. And there's a question around elaborating a bit on what that might look like. I'm going to start with you, Shaun. I know that you're in Canada, but I know that you also are aware of things that are happening in other countries. Do you have any reflections on the differences of diagnosis of ASCVD?
I think, like anything in life, it very much can depend on where you're born, where you grow up, where you live, and there are certainly, from a financial perspective, limitations in various places, and it's not just one country compared to another. Within my own country, there are folks that are at great risk, and there aren't the resources being put in place to help out those at potentially highest risk. And it's going to be a challenge, I think, we need to galvanize. We need to, get everyone together. And as Neil has pointed out, get our governments to make this visible and make it a priority. But in the meantime, I think what's common is the opportunity to increase awareness for individuals, so that even if the healthcare system that they live in isn't making this a priority, there's an opportunity to advocate for oneself and to seek out, a cholesterol test if appropriate, and to seek out a treatment for risk factors. I think that if we can empower the citizens and the patients, that could hopefully even the playing field, and not necessarily only be reliant on our own healthcare system where we happen to to live and work.
Yeah, Magda, maybe the same question to you. Given that you've got a good overview of what happens across Europe, how might you kind of reflect a little bit on differences of diagnosis from country to country?
Last year, we actually conducted a global survey among young physicians and medical students about their knowledge of FH. And those were freshmen who just left university medical schools. Less than 50% of them were able to tell what FH stood for. And the deeper we were digging, the less they actually knew about the condition. That's one area. I can only echo what Dr. Goodman was saying. It is very different between countries. And again, the hospital protocols will be different between one hospital and another one. I'm based in Switzerland, and I can tell you it is the case in Switzerland between different regions. Across Europe, we know it differs. There are some champions. There are some countries that very often you would not even think are very good at detecting and giving the right diagnosis. And I used to call them the underdogs, because those are the very, very small nations that are very successful, but they manage to get it right from the top to bottom with the politicians and policy health ministries involved. One other element that was so well made by Dr. Goodman, we live in an era where it's as well our own individual responsibility. We hear a lot about health literacy. Those who are here today are demonstrating how important it is to be well informed, and I can only applaud you. We have access to a lot of reliable tools right now. Patient engagement, patient responsibility, citizen responsibility is a key factor to get the right diagnosis and to sometimes maybe even challenge your clinician, your doctor, and ask sometimes more difficult questions to get your right diagnosis.
Yeah, great. And, Shaun, there's a question that's been kind of in my mind throughout this time we've spent together, going back to modifiable and non-modifiable risk factors. I guess the question is, can people regulate their cholesterol just with diet and exercise? Because I think a lot of people would desire that, and not like try to stay away from medical intervention. But is that a possibility?
Absolutely. Certainly what we eat, particularly saturated and trans fats and calories, those contribute to the levels of the bad cholesterol floating around in our bloodstream. And so a healthy lifestyle, including, watching what we eat and exercising, those should be for all individuals at risk for ASCVD and those who have high cholesterol. That's definitely an approach that needs to be taken. But as I mentioned earlier, the challenge is a couple. One is the FH situation that Magda's nicely outlined. These individuals, it doesn't matter how well they watch their diet and exercise, they're born with this tendency to make lifelong high levels of bad cholesterol, and so they will need treatment. And then of course, even for those individuals who don't have FH but have high cholesterol and make lifestyle changes, the levels may still be higher than what's safe for the arteries. And so it shouldn't be considered a failure by an individual who's trying to make these lifestyle changes, quitting smoking as well, all of these important things, but they may still have elevated levels. But the good news is that treatment can be, it's very safe, it's been well researched, it's very well tolerated. And so I think we shouldn't beat ourselves up if after an attempt at lifestyle modification by itself isn't necessarily getting us to that sort of target or threshold of cholesterol in the blood that we would like, that these individuals need some treatments.
Support, yeah. So we're almost at time, but I did want to give each of our panelists an opportunity to maybe in one or two sentences, I know that's a little challenging, what one thing would you want our audience to take away from today's event? Let's start with Neil.
Well, I guess if people were to go away from today, I would love them to go away with the message that, we generally have an awareness of we call cardiovascular diseases. And I would like people to stop and think and say, okay, that's a big term, it's a big umbrella. And there's one component under that umbrella, which is called ASCVD, which is a long word. And that's the element that actually is causing the most harm, most damage, and greatest cost. That's the part that we can do something about, ironically, in a significant proportion of cases. But we have just left the burden and harm of this particular subset of cardiovascular disease pretty much go unnoticed in terms of any real intention to tackle it. So we need to start the conversation. So the message from me today is, let's talk about this. Let's get the message out there that this burden is enormous and we need to do something about it. And hopefully through collective engagement and action, we will eventually bring about the change that is required.
Thanks. One or two sentences, Magda.
I would like everyone who's been listening to us today to to leave this meeting empowered with knowledge. So if you suspect any risk of ASCVD or FH specifically, leave this meeting thinking, what can I do today to prevent the consequences? So rather than thinking about cardiovascular disease, you can be thinking about cardiovascular health. Get your cholesterol checked, get your sports trousers, get out, walk, move, and have a healthy diet. Keep your healthy heart and don't get to CVD.
And Shaun.
I just want to echo what both Neil and Magda said very, very nicely. And I just want to pick up on one point that Neil was making before around COVID-19 and the pandemic and how, how was that able to get, countries and worldwide sort of attention and then appropriate sort of interventions to hopefully avoid getting it or to appropriately treat it. I think it's the fact that it affects everyone. And I think that's the key here with ASCVD. It does affect everyone. If not you as an individual, somebody near and dear to you, it affects you. And I think that we need to make that, which is currently sort of invisible. We need to make it visible and continue the conversations around these important topics.
Thank you, Shaun. So I've got a few takeaways. One is that ASCVD just can't be ignored. It's such a massive problem. 300 million people are living with it around the world. Many of them don't know they have it. It's a really important issue to ask your doctor about. We know that comorbidities exist alongside diabetes and high blood pressure. These are things that, again, we need to be going to our doctors about and asking about ASCVD and our specific risks. The scale is massive of this problem, but we can work together. We can work together with our governments, with our healthcare providers, with patient communities and organizations like the Global Heart Hub. We need to challenge the status quo because what is happening today is not acceptable. So I take that away from today. It's been a real pleasure moderating with all of you, such great insights and expertise and knowledge. But before we go, I want to give the last word over to Neil as the host of today's program.
Well, thank you so much, Celina. Can I firstly start by thanking you for your excellent moderation today? You kept the flow going. I thought it was a very interesting discussion. I hope those listening have gathered some nuggets of inspiration, knowledge from the conversation. I want to say a very special thank you to Dr. Shaun. I think you made a very complex topic very easy to understand, and I think that's a challenge very often for a medical profession to sort of translate that science to meaningful words and terms. And so really thank you for that. And Magda, as usual, it's great to collaborate with you and FH Europe. And I know from the Global Heart Hub point of view, we're looking forward to a continued journey in that regard. I want to thank all my colleagues and partners who've made this event possible. I want to thank everybody who joined us today. I hope you got some. I know it was perhaps a little bit heavy at times in terms of it's some of this is bad news, but as we said, there's some very positive messages here. There's messages around us being able to take control, being able to do something, being able to work together and make a difference. So I hope there was something in this for everybody. So thank you all very, very much, and really delighted that you could all be with us today. Thank you.